Behind every master was once a curious student. Every clinical pearl has been earned through years of trial, error, and evolution. Behind every success are stories, challenges, and a unique journey. I'm Dr. David Norcross, and this is Clinical Curiosities, conversations with specialists, innovators, and experts who help move our industry forward.
All right, welcome back to the Full Arch Podcast. It's your host, Dr. Stephen Vorholt. I am recording here from Studio 1A in Phoenix, Arizona. I am here for an implant pathway course, and over the course of this week, before heading out, I was scrolling through Instagram, as I tend to do. Most of my Instagram, like many of the listeners here, is just full of bloody teeth, and I gotta hit the see anyway button. And I saw one that was a guy I've been following for a while. His name's David Norcross, out of Western Australia, and it was a really cool video, and he was explaining, he was like videos of him teaching. And David's joined with us today, so welcome, David. Thanks for joining me.
Thanks for having me on, Stephen.
That video I saw, it was like 3 great pearls that I've heard or said myself since then, and I was just like, man, I'm bad about like connecting on social media, so you're the first comment I've left on a post in maybe months, and the comment was just good stuff or something like that. Yeah. And I was just like, that good stuff.
I feel honored to have your comments.
Yeah,
thanks very much.
You were the one comment for 3 months, and then you were kindly DM'd me, and you were just, hey man, I love the podcast. I'd love to come on. And I was like, oh, beautiful. I'll be in Phoenix. We'll have some time. And so we coordinated with our time zones. It's early morning for you Saturday.
Saturday morning here, yeah. So you're Friday evening, yeah?
Friday at 5 p.m., yeah. So thanks for taking this part of your weekend for this. I appreciate it.
No problem.
Yeah, so I studied abroad in Australia, actually. I was on the East Coast. So I went to QUT in Brisbane. Had a blast. And so I never made it to Western Australia, though.
Well, it's the most isolated city in the world, so most people don't make it here.
Yeah, absolutely it is. I mean, what's the flight from Perth to Sydney must be, 6 hours, 7 hours?
It's about 4.5 going there, and it's 5 coming back. And then Brisbane's about 6 hours, so it's a long flight.
Okay. Yeah, it was the one city I never made it to. I did the Melbourne, Sydney, and up to Cairns and did that whole arc over there.
Yeah.
But I love that country. Well, speaking of Australia, you're not from Australia. So for the listeners, give us a little bio backstory of kind of where you got into dentistry and what led you to WA.
Yeah, sure. So I'm actually from the north of England, so hence the unusual accent, which has now got a little bit of an Australian twang as well. Well, some of my friends home told me. So yeah, I graduated Leeds University in 2006. Probably wasn't that keen a dentist early on. I kind of went into dentistry not really knowing much about it, just because it seemed like a good job. Wasn't really passionate about it, and I probably wasn't the best student at uni either. I was very focused on playing rugby, actually. I played a lot of rugby league, which was actually what first brought me to the Australian shores, and sure enough I actually went to Brisbane and stayed at the university there, so I got picked for England students to come on tour to Australia. So
cool.
We played that East Coast, and that was in 2005, and I immediately fell in love with the country, the lifestyle, the weather, the beaches, the sport, and went home to finish my degree. And it's kind of something I always talked about. I was working in private practice in the UK, doing some implants. I'd done some basic training and was getting into implants. But the economy in the UK at the time in 2011 was pretty poor. We tried to buy a practice, it fell through. So I ended up just going, right, let's go to Australia. I'm just going to go get a flight, try and get a job. And I originally wanted to go to the East Coast, but nobody would really take me on because I was just planning on going for a year. And then there was a company in Perth who were offering sponsorships to UK dentists, like a visa. Got chatting to them, and they sent me a picture of this beautiful beach and said, you'll be working just down the road from this beach. And I was like, sign me up. And that was 2011, and I planned to come for 1 year and then go back, and I never left. So I've been here ever since. Yeah.
That's awesome.
Yeah.
When you moved there, did you come with any family with you, or did you just come by yourself? Or?
Yeah, I came with a partner. So we came together, and equally, she fell in love with the country as well. So now I've got my passport. I don't think I'll ever wear an Australian rugby shirt, but it's home for me now, and it's been great. The dentistry was good here when we came. It was mainly private. In the UK, there's obviously the NHS system, which is a public system, so it makes it difficult sometimes to do high quality dentistry. And I got an interesting sort of pathway when it came to my work, which I'm sure we'll talk about because it's kind of led me into implants and teaching. But it was a good place, good place to live. lifestyle is good. It's very relaxed here. It's, people get up early, they go to the beach, they exercise. It's probably not as crazy at night time as it would be in the UK, and also where you are in Phoenix. I was actually in Phoenix a few months ago. Actually, had a crazy night out in Scottsdale, which was fun. So yeah, it was just a good move, and never looked back really.
That's awesome. I ended up studying abroad there, and then I dated a gal from Brisbane for a while, and I got into dental school. And I remember when I getting into dental school, I remember looking briefly into is it possible to get a U.S. dental license and then transfer to Australia? And it was a whole. I talked to Lincoln Harris about it for a while.
Yeah, okay.
Back in 2010. And it was a nightmare. And the race that ended up not working out because, we were literally 12 time zones apart. But for the UK, I think, from what I understand, meeting some people down there studying abroad, their law system was similar enough where some law students could just kind of transfer. So now you had to go with sponsorship, though, it sounds like. Now do you have your own Australian license, or how'd that work out?
Yeah, so the actual dental license is easily transferable. We don't have to do any additional exams because it's fully recognized here. But you need a visa to work here. So you can either come on a working holiday visa. I think UK people get 2 years to come here and work, but that's more backpackers. With dentistry, you need a sponsorship or residency. So I had a sponsorship originally by a corporate group I've worked with for many years still, but I was able to get my residency it's basically just a lot of paperwork, and you have to have been here for so long. And then once you get your permanent residency, you can then apply for citizenship. So I actually now have dual passports. I have a UK passport and I have an Australian passport as well.
Ah, brilliant. Okay.
Yeah.
I love that country. I haven't been back since, it's probably been 2012, but I went back and forth 4 or 5 times. And I remember those flights from LA were a 13-hour flight. Yeah. That has made every flight in my life since feel quite reasonable. If I go from LA, I live in Santa Barbara, California now, though I'm in Phoenix quite a bit. But going for the East Coast is a 5.5-hour flight, and it feels like nothing because I still, in the back of my mind, remember those trans-Pacific flights. Yeah. But, that's really exciting. So, obviously better weather. I think there's no question that Australia has amazing weather, beaches, and people. The people are so kind down there. So implants, you were kind enough to kind of send me a little bit of background on yourself, just so I kind of knew your timeline. But it sounds like this corporate group you went to, you walked into an office that maybe wasn't, how do I put this nicely? Maybe it needed a little bit of help on the back end.
That's an understatement, yeah. I was placed in a practice that basically, because they knew I wanted to learn about implants, they placed me at a practice that was doing hundreds of implants per year. But within a short time of being there, I sort of realized that something wasn't quite right about how the implants were being done. And sure enough, the principal dentist at the time, who had sold to this corporate, actually got struck off. So he lost his license for malpractice related to multiple complaints, cases to do with implants. So I kind of walked into this practice knowing a little bit about implants. The corporate group then asked me to take over and said, look, can you run this practice now? We've sacked him. He's gone. He can't practice anymore. Will you take it over? I thought, great. What an opportunity this is to run my first practice. But within, just a few months, it was a nightmare because they had been doing, him and another dentist who also subsequently lost his license, had been doing a high volume of, not just simple implants, but full arch cases, high volume for a long time, and we were just getting this tidal wave of complications coming in. And because we were in the practice in the same building, it was okay, this is now your problem, you need to fix it.
Absolutely.
So it was a real headache and real hard, tough time for a good few years, and even I'd say 14 years on, we're still seeing some of the complications coming back at that practice. But what it did do, it sort of really opened my eyes to, okay, when things go wrong, it can be a real mess when we're talking implants, especially full arch, not just clinically, but psychologically to the patient, the reputation of the practice, and the profession as well. So that's what kind of kick-started my implant career, which was, okay, I need help. I need to know this really, really well. A, to help these patients, and B, to make sure I don't have this sort of result with my own cases. So
what was, if you could pinpoint the top 3 issues, what was the biggest problems they were doing there?
Look, it was just combination of poor planning, poor patient selection, and then just really poor execution. I think we both know, being experienced in the implant space, the main cause of complications generally you can track back to some form of operator error, in my opinion. It may be the wrong patient selected or just the way the surgery has been executed. Like, I think for me, that's generally the first factor I look back at to track a complication of failure is, okay, how was this implant placed and how was the patient selected correctly?
Yeah.
I always look at that. I always look at that factor before patient factor,
Yeah, it's very easy to blame the lab, blame the patient, and that's probably what those doctors did before then. But there's almost I'd say 90% of restorative complications go back to the planning.
100%.
And why is the screw coming loose all the time? Why is this breaking? Oh, they didn't do enough this. They put the implant here and there. So I agree with you. Certainly a lot of stuff. And to a lot of us, like myself, when I started practicing implants, the first 6 months is the perfect Dunning-Kruger curve, because the first 6 months you've yet to restore or see any of these things. You're like, this is great. They're all healing because no one's in pain. Yeah. And then 6 months later you start restoring them and realizing, why can't I restore this first implant I placed very well? So you get kicked in the ass. But then you run into these kind of sociopathic tendencies where you're like, they did this for years and never learned the lesson. So what are we doing here? So good on you for getting through that. It sounds like it took several years, and it sounds like even there's still some repercussions. But you and I have a similar track in the sense that when I joined Implant Pathway to lead one of the clinics, there wasn't an abundance of errors. There was a huge volume here, but so naturally we saw a lot of complications. But when I came in, I had placed maybe 200 myself. I had done a couple of overdentures and many hundred singles. So I knew kind of what was necessary. I had some background, and then the crucible, it sounds like you and I were both in, of just like, we are now surrounded by only implant things, whether it's good, bad, or ugly, and you either sink or swim. And someone like yourself that stuck it out, and now you can go back and you've started to teach, and we'll get into that in a second. But the mindset of you as a teacher, having seen all of that, it sounds like you focus a lot more on those complications, even in your beginner classes. Would you say that's true? Is that you kind of make sure that people know that on the upfront side?
Yeah, I think, look, your experience shapes you, doesn't it? So, I experienced a high volume of complications. So I'll be honest with you, early on, it sort of put doubts in my mind about, things like the all-on-4 concepts. It's like, does this actually work? Because this guy was sticking 4 implants in and they were failing. So, my initial thought was, maybe this technique doesn't work. But then you realize, okay, it does work if the protocol is followed properly and it's executed very well. And we both know full arch is quite forgiving. Some people can do it to a fairly average standard and get away with it. But then when you look at it 4, 5, 6 years later, that's when we see, okay, this is not lasting like it should be because, again, we go back to how it was executed. So yeah, it probably warped my experience and opinion of implants in some ways, but it was also good because I saw all the complications, but they weren't mine. Although I was dealing with them, I got a fast track education in every single complication that you can see, really. So it was good in that way. I don't think I would do it again because of the stress levels, and it's hard because I think most of us want to do the right thing by the patient, but when you've got a patient who's paid a lot of money and they come in with their implants literally in their hands or they're having problems, it's heartbreaking for the patient, and you just want to help them, but sometimes by that stage it's too late to help them. Some of them can be so badly damaged that it's then hard to retreat. So yeah, I think definitely focus on executing things really well and talking about complication and being upfront about our own as well. So that people realize it's not all rosy and it's not everything you see on Instagram, which is great and perfect. Stuff goes wrong.
One of the first reasons I started to get more followers on Instagram was I was sharing a lot of complications, and what mine or just ones that had come into the office I was working in. And I teach a complications course now that's 2 days. The next one is in DC, September 12th, and then I'm doing one in Vegas the next weekend on the 19th and 20th. And it's very popular because I've had people come who have never placed an implant, which I usually kind of make a joke that, like, if you take this course now, you might never place implants. Usually it's someone who's placed maybe in the 50 to 100 implants and they're starting to see some stuff, or they don't want to see some stuff. But I think it's great. It is hard. And like what you had mentioned is you like to at least go a little bit deeper into the potential complications while explaining how to do this. And whenever I make like a 1 or 2 day lecture on implants, I struggle to find enough space because you're trying to jam so much info. It is hard to slide enough complications in there that wouldn't A, freak somebody out, or B, just kind of take over, because there's so much content there. That's why I had to make a course by itself. But I'm looking forward to hearing kind of how you incorporate that into your coursework, because it's necessary. It's very, very very necessary. So you're down in your Western Australia at this place in Perth. You worked there for the better part of a decade, maybe even a little longer. When did you start doing teaching and giving back, and when did that kind of come in?
Yeah, so off the back of what we did with that practice and fixing it up, the same corporate group asked me to take over 2 more of their practices that were struggling a little bit. And obviously with that came multiple dentists, and I'd done a lot of education by this stage and was very committed. And because I was mentoring a lot, then that sort of led into teaching as well and putting together my own courses, which started off with basic implants. And then as I became more into the full arch, all on 4 and full arch space, I did a lot of courses. And like you say, I found some of them a little bit limited and missing key bits of information. I worked closely with Noble Biocare, who, credit to them, originally they were kind of reluctant to put on all on 4 and full arch cases because they didn't really want to teach potentially doctors who shouldn't be doing it. But I kind of had a discussion with them and said, look, better that we teach them and teach them well than them go somewhere else, and hopefully then they'll use your implants if you'll have mutual benefit to that. And that's kind of how we developed the full arching courses. We wanted it to be very comprehensive, open, honest, talk about not just the surgery and the protocols, but the patient side of things, the patient management. How do we manage them from a psychological point of view? How do you select the right patients? It's very easy to take on a full arch patient, but if they don't fit with you and your practice, you're then married to them for the whole of your career. So you also have to select the people you treat carefully. And we this year we would have turned away maybe 2 or 3 patients just because they say, hey, you're not the right fit for our practice. I don't think that so your expectations maybe match, or your understanding match what we want to do. So we teach that as well, and I think that's an important part, and one that we get a lot of good feedback about. They kind of just think that we treat every case that walks through the door.
Yeah, I think there's a saying I've heard before that's like, I've never regretted the patients I said no to, but I've certainly regretted some patients I've said yes to, as far as who you treat.
We've all got them. We've all got them.
Yes, and if you ask any implant or any dentist really, if they can think of someone they don't want to see on the schedule, there's 2 or 3 names that are just pre-populated right in their head. When it comes to Australia, what is the CE scene like there for implants? I know that who's the guy who does the Australian implant program down there? It's like a very comprehensive David something. I mean, not you. There's another David, but there's he's somewhere on the East Coast, I want to say. But in the U.S., it's just we're just full of CE opportunities and different centers. And Phoenix is a hub for it by itself. There's some on the East Coast. There's maxi courses all over. In Australia, if someone were to want to learn, some GP want to learn implants, what is the kind of the go there? Because I've actually run into Australian dentists here who flew all the way to Phoenix to do this.
We travel. I mean, especially being in Perth, West Australia. Most of the courses that I've done have been on the East Coast. So Sydney, Melbourne. Brannemark, we do have a Brannemark centre in Perth, so that's where I did a lot of my initial training, and that's how obviously where Nobel have a good footprint in Perth. But generally we would be expected to have to travel over east. More and more courses are kind of coming to Perth, our own, and I've got some other colleagues running some great courses now, which is good. But there is good CE here. You mentioned Lincoln Harris before. I think he's done a lot of CE in Australia. I did the guide program with Sasha Jovanovic, which was excellent, and so they have an Australian-based one. I did that. I think that was back in 2012, and that kind of probably changed my career actually, in seeing general dentists and specialists in that group doing amazing work. Like really good documentation, and that's again what pushed me to document. We document all our cases. We photograph every single surgery, which has that's been a great learning tool for us, because, if we do get a complication 4 or 5 years down the track, we can track back to the surgery photos and say, okay, where was that implant? That one was 1 millimeter more buccal than we should have been. That's why we've got soft tissue loss around the multi-unit. Little things like that, which have been really good. And a lot of that stemmed from going on those, CE courses early on.
Yeah, I actually got the camera out this week for 2 of my cases to take some pictures, and my staff were like, oh my gosh, we haven't seen the camera in a while. So I've just been, like, the better part of this year, I've just kind of been head down doing cases, trying to work on my efficiency and getting faster and faster. I shouldn't say faster and faster. Efficient's a nice way to put it, because obviously we're trying to be very thorough as well. But the camera was a very big time suck for me, because it's gloves off, it's camera, it's this. So I finally got it back out for a couple of cases. I love to reincorporate it into more of my cases like you're describing, where it kind of becomes part of the, this is when we stop and take a photo. Because I've never learned more than like what you're describing, where something goes wrong and you have the picture and you can go back and maybe have some data or some clues of what's going on. What's your camera setup like? Do you videotape stuff, or is it all all DSLR?
So we have a mix. I mean, the best way to do it is obviously have your team photograph. So, when we're so I do a mix of surgery. I do some in the practice under IV sedation. We're not allowed to do general anesthetic in our rooms in Perth in particular. And then we travel to a day surgery to do general anesthetic treatment. So in the day theatre, we'll just use an iPhone. Literally, the quality of the iPhone is normally good enough to get a decent surgical photo. We video things mainly for the education courses. If we see anything that's interesting or cool, we'll video that. We may post that on Instagram, which is again where we get a lot of interest about the courses and questions. Mentioned before, if I post any sort of complication on my stories, my inbox just lights up. Oh, good on you, that's amazing. And I'm like, what? It shouldn't be like that. It shouldn't be that we're abnormal showing complications, because it's a massive part of our industry. It's what we, it's what happens. So that interesting. But yeah, I think for me, the team know as well. If now my team, if we do something and my nurse will go, hey, let's get a video of this. This is good. This is interesting. Let's do that. So it's kind of a team effort. They know that we document everything. They know that it's really useful in the teaching courses, and it's really good, a learning tool to then track the cases. So they're on board, and I think that's the main thing. Is then it just becomes part of your workflow.
Is there any particular photos? It's is it immediate post implant insertion? We always snap a photos, or is it after multi units are on? Is there any we got to get these 3?
Yeah, generally I'll do initial flap reflection, teeth out, initial flap reflection, photo of the alveoplasty, because that can also help you see, certain sockets that might be really thin, which would then you get tissue recession in that area, then implant position, multi-unit position, and then closure, so that we can then track how the soft tissue heals. So those would be the main ones that we photograph.
You're inspiring me to change my whiteboard in the surgical op and just kind of write down the 5. These are the 5 we get a photo of. It doesn't have to be fancy. iPhones, you said, take amazing pictures. It's kind of unreal how good they are. And meanwhile, I've got this $2,000 camera I'm trying to wedge into the mouth to get a picture. So that's a good point. All right, I'm back on board with photos.
Do it.
This week I've been teaching, and most of the docs here at this particular course, this is the flagship course where they're placing their first implants. And they do an arch, typically an overdenture arch, on Friday, like today. And after our initial conversation on Monday or Tuesday when we talked, and I was reading through your stuff, I kind of was a little bit more focused on teaching the why. And so it's very easy in these courses, especially when you come in just as a faculty to do the surgery, to kind of show them how efficient they can be. Hey, do this, do that, and just make them be your hands. Do this, do that. And they're just listening. And so this week I tried to be more for instance, we had a number 3 extraction graft, and the buccal roots were completely dehisced. This is just a big notch in the buccal plate. And we knew it was going to happen on the CT. We had talked about it. And so I asked, okay, what should we do to rebuild this? And they're just kind of looking at me you tell us. And I said, no. What have you learned over this week? Let's find the limit of your competence so that I could extend it. And so they were talking to me, they throw out, well, maybe we should do PTFE membrane. Okay, why would you do a PTFE membrane? And so I think that helped me kind of hopefully not just annoy them I didn't want to make them feel incompetent or that they don't know something, but it was hopefully okay, we're building the blocks of the why, which goes back to teaching the complications is one thing, but it's why did this complication happen? Let's go back to remember why we talked about we want to be more lingual than buccal and this and that. And so when you do courses, do you have a similar mindset where it's it's so easy for patients, or I say patients, but for attendees to come and just want a cookbook? Just tell me the 5 steps to go, and it's it doesn't work that way. This is an art more than a science. How do you approach that in your lecturing space? We try and make sure they're pre-prepared, so we send them information. And look, not everyone will come pre-prepared. They just want to be spoon-fed. But, and I think that's a shame. I track back to when I used to go and, observe a surgery. They'd ask you questions, and they'd expect you to know your stuff, just the fact that you're there, So, we encourage them to obviously pre-read. We try and involve them. I'm mic'd up during the surgery, explaining as I go. So on the full arch in residency in Perth, and we're taking it to Melbourne as well in November. We do 2 live surgeries so that they can try and link up, what we're talking about in the lectures with the surgery and say, okay, that's the protocol that we taught you. Here's why we do that. See this? And try and get them interactive. We try and keep the groups pretty small. So maybe say we max 12 so that they have chance to interact and ask those questions. So those are the main things that we do is try and pre-prepare them, encourage them
that, hey, you will get the most out of this course if you come with good knowledge as well.
Yeah, because what questions can you ask if you don't have an understanding of why you'd be asking something? Right?
Yeah.
And so true. I actually I had the first doc I worked with this week, his name is Spencer. Shout out to Spencer. He had placed 10 to 30 implants and done like 1 lower 2 implant over, something like that. He had some knowledge, and working with him was very different than working with someone we were going to place their first ever implant. And there's nothing wrong with the person who wants their first implant. It's great to do that under mentorship and direct guidance, but he had a different level of questions. And so it's just nice to have someone, whether they had read the material you sent them, have read textbooks, have followed people on Instagram, it makes for a much more enjoyable experience, honestly, for you as a teacher, if you're the same as me, because you get to kind of go to the next level and not just describe the physical, how do we do this stuff. So the full arching course, it sounds like it's a lecture and then you doing a couple surgeries, and the rooms look very large, so it looks like your attendees are in there with you watching.
Yeah, so we do, it's 4 days, it's pretty intense, and look, I have been a traditional all-on-4ist, so it was, all-on-4 was the protocol we used, but then also I've always had an open mind, so we've integrated pterygoid implants into our workflow as well. Not all the time, I don't follow the Patsy protocol. I sort of have my own take on that, which I think it's a great tool that we've used, but it's not always necessary and potentially overused in some cases. So we teach that, we teach that as well, but how we do it. So we generally do 4 days, which is a mix of lectures, hands-on with models, so that they drill into 3D printed models, and then 2 live surgeries where they can see a 3D print of the CBCT of that surgery. We can go through that surgery, and then obviously I do it live, where we're mic'd up. It's either under general or IV sedation, depending on which clinic we're doing it at. And then it just kind of brings everything together, so it covers everything really, from the most basic up to the advanced. And like you said before, it is certainly easier. We have a mix of people coming. We have those that have a small amount of full arch experience, but we also have those that have maybe done 50, 100 arches, who really want to refine their skills and advance the techniques.
That's fantastic. Are you doing it analog or digital on the same day restorative portion? How do you do
so
that?
we touch on analog, because I have been traditionally analog until probably the last 2 years. Was doing your general splintered impressions, bite reg. We have generally for the last 7-8 years gone straight to tie bar in the same week. But we focus more on the digital side of things this last couple of years. So we were doing 1 case analog and then 1 case digital, but we kind of finding that the analog it is being phased out. I think it's important to know it and understand it. But I think we all know that with scanning and photogrammetry, that's kind of the way that everyone is shifting. So the last course course we just did digital workflow with the live patients.
Okay. I mean, and honestly, I'll meet people who are wanting to get into All-on-X, and they want to go digital day one. Like, no one wants to go through the pain most of us went through at the beginning. So we have a course I teach with Dr. Miller called Intro to All-on-X, and the level 1 was essentially analog. It was treatment planning, patient management, all the way from like prescriptions, consents, all the way to the surgical protocols, and then analog. And then we made level 2, which was just kind of the same thing but digital, and we're never going to do that again, because everyone in the level 1 was just kind of peeking over the fence at the level 2, just like, oh, we want to learn that. So we're gonna phase out the analog and just kind of combine the two, because that's what everyone wants, and for good reason. It is clearly a smoother transition. So when you did the digital this last course, do you have a preferred setup as far as photogrammetry, scanning, that kind of stuff? Yeah,
so we have an iMetric at the practice now, so that's my preferred option for implant capture. We played around with, and again, shifting from analog when you've done it for so long to digital, I hated it because I just didn't find it as predictable, because I didn't understand the digital workflow. I didn't understand that it's all about reference points and giving them as much data as possible. I was just doing these intraoral scans and the bite was coming back all over the place, and I was like, oh, this is rubbish, it doesn't work. But then we incorporated the palatal markers. We used some bite guides that are relined. I don't tend to put markers in the mandible. I do find that it slows me down and kind of affect the neatness of my surgery. Like, I'm a real stickler for having really neat surgery, so we just use bite guides that are relined over the healing caps, so that's generally enough for them to align the data, and then we'll generally do a same day or next day printed provisional try-in, which we can then adjust the bite, and then we'll rescan that and they'll mill a bar for us so that we can fit that a few days later.
Gotcha. Is the bar they're getting that week, is it PMMA wrapped, or are you going straight to zirconia or hybrid?
Nah,
How are we doing that?
still using PMMA at the moment. Again, that's my traditional outlook. Having something softer in there that they can, you can adjust the bite, you can let them get used to it for a little while before we would transition to the zirconia. But again, I've got an open mind. I know a lot of you guys in the States are going straight to zirconia now. I think certainly zirconia from a maintenance point of view is much better, but I'm kind of hanging back a little bit just to see what all the longer term stuff looks like before I incorporate it into my own workflow.
My fear has always been that, and there's some people who can do this, but I think it's the exception to the rule, is managing the tissue to the point where you don't have to, if the tissue swelling goes down and you have your final prosthetic in at week 1, at week 10, the patient's like, I'm getting a whistle, I'm getting a blah, blah, blah. Yeah. Some people, like in Brazil, the course we did recently, everything is a tie-wrapped acrylic. It's like old school. Yeah. And when they get them at week 8, 10, whatever, they'll just flow more acrylic in the lab, and they're just like, okay, now you're done.
Yeah.
And you can't do that with zirconia, of course. PMMA, you at least have the option to rewrap it with a different material down the road. So I've seen it go both ways. There's a couple surgeons that I respect the hell out of who do it, but it's like they must have amazing management, and like they're doing bone level scans, and they know their stuff. But it's not meant for the everyday person. I had another friend who did it for about 3 months, and then was like, half of these I'm having to retread. So he went back to a more of a temporary, and then we'll rescan you in 10 weeks.
Yeah.
It all works if it's working in your hands. You just don't want to have someone who goes to final and then is like, well, accept the huge gap under the integument for the rest of your life.
Yeah.
Speaking of the course, so you have a course coming up soon in Perth, and when's the one in Melbourne? You said you have one in Melbourne coming up?
Yeah, so we ran one in, when was it? It was May, just when I got back from the US, in Perth. We've got one in November 23rd, 26th over in Melbourne. But we've also linked up now with a clinic in Dubai to run a live surgery component. So we take 8 delegates over once or twice a year, where they actually get to do full arch surgery on live patients under our supervision. So we've got the next one in October. There's actually I think there's only 1 or 2 spaces left now. So that's about 8 weeks away, I think. So yeah, we'll go over. They're reasonably experienced already in full arch and implants, and we'll have cases lined up for them. They normally do, so again, it's a 4-day course. We do a day of lectures and case planning, and then they'll do 3 days of back-to-back surgery, where they normally, we pair them up, and they normally do 2 arches a day between the 2 of them. So either a dual arch or 2 singles, and we can generally cater the cases for their experience level. So if we've got someone who just wants to do standard all-on-4, or we might have someone who wants to do more palatal approach and pterygoid implants, we can fit them with the right patient. So our next one's in October. We had a hugely successful one in March. We had a great group, and they got a lot out of it. Like seeing the progress of their surgery over the 3 days was amazing. So it was good.
That's cool.
It was good
Live surgery is a whole other level. Do you vet the attendees? Do they have to have taken your course before with you, or is it just
Yeah, so the group I've linked with in Dubai, they initially sort of said, will you come and teach on our courses? But I kind of said, look, prefer it if I could run my own, so we can carefully select the delegates, because I don't want to be responsible if they're coming in without surgical experience. So yeah, we vet them and make sure they've got a level of training, and then we'll do some Zoom lectures prior to the visit to Dubai to make sure that they're well prepared, and so that I can teach them my protocols, which may be slightly different to what they've learned before. But yeah, it worked well. We were there in March, and we're back there in a few weeks.
That's 3 days of back-to-back surgery. That's a lot of experience. That's amazing. Now, is there any limit to where internationally what their license is, or they have to be UK based in the?
Most, I think, they operate under a temporary license, so the clinic have got an agreement there. So we've only taken Australian and UK delegates so far. We have had some interest from the US, but I believe they would also be able to get the temporary license.
Nice.
But I saw you went to Brazil recently. I was there a few years ago myself doing a Zygo course, so that was where I got my first taste of live surgery over there.
Yeah, it's wild. Were you I went to Ilapeo, which is where Neodent is kind of headquartered. Does Nobel have a space in Brazil somewhere?
No, I was in Sao Paulo with a guy called Professor Salvoni, and I went with a UK group. So it was actually Norris implants that he was using.
Sure.
So yeah.
Sure. It's bizarre. I mean, they have a different mindset to how they do stuff, like we talked about in the podcast in the last month. But it was great to see it. But even that course was 1 day of zygo surgeries.
Yeah,
like,
right.
It was only 1 day, and I was like, so there's only so much I could take away. I mean, I placed myself 2 zygos, right? So like one on each case. So I was talking today. Chris Barrett was in town teaching this course with me, and I was just like, hey. It's been 2 months since Brazil. Like, I've already lost the magic dust. Like, if the week after I got back I'd had one, maybe I could have felt. So I'm looking forward to getting him or Dan or Juan or somebody out over my shoulder whenever I can find a patient. And then you get back to your practice, and I focus mostly on all in 4 cases, and it's pretty rare still that I find one that's like, oh, this is a zygote case. So I need someone to walk across the threshold who needs it and willing to go it. But honestly, back to your point about pterygoids and stuff, like, I don't really go outside the bounds of all in 4 too frequently. I've been trained on these things. Yeah. But I saw a case the other day that was like some post-op CT showing off what they'd done, and it was a double arch, and they were talking about the cumulative torque on the top and all this kind of stuff. And they had, 2 anterior, 2 tilteds, and these 2 pterygoids. Looked great. The bottom arch, when they flipped to the full screen CT view, had 2 tilteds and 2 straights, and the tilted on the top was more posterior than the tilted on the bottom. Yeah. And I was like, what cantilever are you protecting from going back there? I laugh a lot when I see these cases because I love Dan so much, and I respect the hell out of him and what he's built with the Patsy protocol and stuff, but maybe it should be the ATSI-P. I'm not sure it needs to go straight to pterygoids, but to each their own, and people have an opinion. The U.S. seems to be leaning that way. The zeitgeist seems to be kind of moving that way. Yeah. But Brazil is not. Brazil is just like pterygoids. No, what pterygoids? What are you talking about? So it's always good to see these different kind of protocols. They all work. Yeah. So pick and choose your own adventure kind of thing. But I think exciting.
You got to be careful as well because, is it a protocol because that's what we need to do, or is it a protocol because someone's tried to create a new brand for themselves and a new niche? The pterygoid has got me out of trouble quite a lot of times when you've got really poor spread or torque and the patient, really wants an immediate load. Dan Holscore's done amazing work. I did some training with Juan when he came over to Sydney. But yeah, I think as well, if you're dealing with the restorative aspect and not just handing it over to someone else, that's where your mindset changes as well. You do a great Patsy protocol, but then you're like, oh, I've got 6 screws to put in here. I've got 6 holes to fill. Like, this could have done with just 4.
Yeah, and I can't even reach these back teeth. They're so far back. Or if the patient opens wide enough for me to reach them, then the coronoid process blocks my access to the hole because I put it too buccal or whatever. There's all sorts of little nuances like that. But so the Melbourne, I've been to Melbourne once. I love Melbourne. Melbourne's a really cool city. So how many people go to those courses? You said 12?
So we'll cap that at 12. So I operate in Melbourne myself. So one of the delegates that came on our full arching course, he has a clinic over in Melbourne, does a lot of all on 4, and I go over every couple of months to help them with the more complex cases. So, if they've got a really atrophic case, then I'll fly in and do a few arches over a couple of days. So that and we run a study club over there as well with Nobel. So we get, 20, 25 people coming to the study club. So we just decided to say, hey, we'll run the full arching course over there. So there's been some interest there, and we'll do that at a clinic where we can do the live surgery under general anesthetic as well. So yeah, it'd be cool.
Nice.
Be good.
That's very nice. Well, are there any plans for you to go do CE yourself? Do you come to the States very often? You said you were in Phoenix a couple months ago.
Yeah, so I was over in Vegas for the Noble Biocare conference. It was actually only my second time in the US. Prior to that was for the guide program with Sasha Ivanovic, and then I decided to stop off in Phoenix. There's another Nobel guy called Joe Mernfar who does.
Oh yeah, I know Joe very well.
Yes, so I went and we connected. Where else? Over Instagram, and I know he's a key opinion leader for Sprint Ray and with our stuff in digital. But the main thing is because I've actually bought a new clinic, so I'm leaving the corporate environment at the end of the year, and I've bought a new clinic in Perth, which is a bit close to home, and the plan is to turn it into an implant centre, but also with an education centre. So I was really keen to go and see Joe's facility in Scottsdale because I know he does a lot of education. So he was great guy, Joe. Shout out to Joe if he does listen to the podcast. Absolutely. He was very welcoming and hung out with those guys for a couple of days, watched how they do surgery, had a look at their education centre and came back with, a lot of ideas. And One thing I really like over in the US is how you do utilize your team in the consults and things like that, and something that we'll look to do more of here. I think here generally it's the dentist that does everything, whereas I know you guys, you definitely utilize your team a lot better than we do, I think.
Yeah, well, a lot of the dentists here, myself included, would just mess it up if we were in there talking for too long. We'd get way too technical or way too deep or all that kind of stuff. But Joe's great. He was, when I did my year stint where I was doing traveling surgery, there was an office where I was kind of backfilling for him. He was starting to get more busy at that clinic that you described, and he was kind of backing off, and so they were bringing me in, and so I got to overlap with him a couple of days where he'd be doing an arch and I was doing the singles and the sinus lifts and stuff like that. And I watched him do a lower arch in 35 minutes flat or something like that. And I think at the time, I don't think he was doing digital at that office. I mean, obviously he's a digital guy, but I think there they had a lab tech or something like that.
Yeah.
But I remember just being like, holy crap. Like, I watched this 35 minutes lower from like shot to knot, and I was just blown away. And I sat down and talked to him at lunch, and he showed me all these things he had built with the bite stent, and I was just like, my mind was blown. He's a genius.
Yeah.
But I wish I got to connect with him more before. Then I moved from Phoenix, so I really haven't connected with him much since. But, well, that's cool. It's a small world, especially when you get into the KOL game where it's like you guys are both Nobel guys. It becomes a really small world where we probably all know the same, like 150 people. I mean, we all follow each other on Instagram. It's funny.
And but Instagram's been great in that way to connect us all, like just seeing what other people are doing, and then if I travel, if I ever go and do a course, or even when I go back to the UK now and see my family, I'll always try and pop in and see someone who's either KOL or I follow on Instagram, or go and see their clinic just for more ideas. I think it's opened up a lot more lines of communication in our field, and we're able to learn from each other, which is great.
Yeah, I would love to get back down to Oz, man, because like it's been over 10 years. If there's ever a big implant conference or something, I need to just, there was an ICOI was there a couple of years back, and I wasn't able to make that one, but I'd love to get down there. If we're ever down there together, or you ever come back up here, of course, reach out to me. But unfortunately, it's 6 o'clock my time. They're going to kick me out of this building. I think the doors all lock in a couple minutes, but it's been an absolute pleasure to talk to you trans-Pacifically. Any parting thoughts? And please let us know how listeners can follow you on Instagram. If they maybe want to look into that Dubai course, how would they reach out?
Yeah, so you just go to Dr.Dave Norcross and look it up online there. Do you have a link? Do you have a show note link? Or
I can put a show note link.
Yeah, I can send you that. And then Dr.Dave Norcross on Instagram, where we share a lot of info about the courses and everything. And if anyone's ever over in Western Australia and wants to come and visit, we always welcome people in to hang out and see what we do.
Yeah, if I'm ever in the most isolated big city in the world, I'll be sure to reach out, because I don't know anyone else there, but that's fantastic. Oh, man. Well, it's been a pleasure, man. I appreciate it. And for the listeners, look up Dave Norcross on Instagram. That's where I reached out to him. And then his website, we'll put it down in the show notes. Otherwise, we will see you next week, or listen to you next week on another episode of the Full Arch Podcast. Cheers, everybody. Thanks, Dave.
Thanks. Have a good evening. See ya.